Good evening, everyone. I would like first to thank Dr. Hanan Al-Rayes and my colleague Dr. Fahid Da'nizi for this organization. And on top of that, Pfizer company, Dr. Khalid, for this excellent organization. And of course, the company for organizing my presentation. So my topic for tonight is ANCA-associated small vessel vasculitis. It's very hot subject and challenging topic at the same time. As you know, ANCA-associated vasculitis is a serious and often life-threatening disease. And usually it's linked to two types of antibodies, PR3 and MPO ANCA. So before I go to the studies that were presented in the EULAR 2020, I would like to take you through this beautiful algorithm. This is from EULAR recommendation 2016. And what they told us in this recommendation that we have like three phases in management of a new ANCA-associated vasculitis. The first phase is induction phase, and the second phase maintenance, and the third phase is follow-up and titration the medication. So I will try to tell you what studies came after 2016 until 2019. Then I will go to the studies that were presented in 2020 to conclude from all these studies what we can take from all this. So as we know, if we have patient with ANCA-associated vasculitis without organ life-threatening disease, we can induce our patient with either methotrexate or Silsibt along with the glucocorticoid. And if we have a patient with life-threatening disease, the recommendation is from EULAR, we have to induce our patient with either cyclophosphamide or rituximab along with high-dose glucocorticoid. However, there was a new studies was published in 2019, MICES study. They did compare the rule of Silsibt with cyclophosphamide, and the result was really beautiful. And the Silsibt was not inferior to cyclophosphamide, especially for patients with MPO ANCA associated vasculitis. However, there was higher relapse rate, like double of the rate in patients with PR3 ANCA associated vasculitis. So from this study, we can conclude that we can use Silsibt as alternative for cyclophosphamide or rituximab as induction therapy, especially for patients with MPO ANCA associated vasculitis. Another thing, from this recommendation, EULAR recommendation in 2016 that advise us to use plasma exchange in patients with rapidly progressive renal failure or pulmonary hemorrhage. However, the rule of plasma exchange was revisited recently in the recent study which was published in a New England Journal of Medicine in February 2020, Bixivas trial, and the result was against this recommendation. And the conclusion from this study was, among patients with severe ANCA-associated vasculitis, the use of plasma exchange didn't reduce the incidence of death or end-stage kidney disease. And another beautiful finding from this study, a reduced dose regimen of glucocorticoid was non-inferior to a standard dose regimen with respect to death or end-stage kidney disease. And what I meant by reduced dose regimen, almost 60% less than the standard dose when they compare it as a cumulative dose. So this is second beautiful finding from this studies that we can use reduced dose regimen of glucocorticoid. Now let's move to the maintenance phase, and I will tell you where we are. So from EULAR recommendation 2016, they did recommend us to use AZA or methotrexate or rituximab during the maintenance phase. However, I will elaborate further about this maintenance phase during my talk, and I will compare it with the new study that was presented in EULAR 2020. And this phase followed by a follow-up phase, which is after usually 2 years. From this stage, we can titrate our patient gradually according to the situation of our patient. And another thing that I would like to mention before I go to the EULAR 2020 studies, as we know, the commonest cause of death in patient with ANCA-associated vasculitis is infection. It's like 9 times the risk of death as compared with control group, and mainly because of the infection. And the commonest cause of infection is our medication, unfortunately. And on top of that is high dose of glucocorticoid. That's why there was a study was published in 2017, and in this study they did compare the role of avacopan, which is complement 5 antagonist receptor. They did compare it to glucocorticoid, and the result was beautiful. It revealed non-inferiority of avacopan, which is complement 5 antagonist, to the steroid. And even the renal function was much better in patients with avacopan group, and even the life of the patient was much better. However, the side effect in terms of hepatic dysfunction and leukopenia was higher in patients with avacopan group. Now let's move to the first study that was presented with regard to this talk. The title for this study was Maintenance Treatment for ANCA-associated vasculitis in Real-World Practice in Europe, Reality of Vasculitis Remission and Relapse and Significant Burden of the Disease. I will jump to the objective for this study. They want to define and to understand further the maintenance phase and when it will begin. And this study was retrospective observational study. They did involve around 500 physicians from nephrology service, rheumatology, and internal medicine from different countries in Europe. And in this study, the physician did complete retrospectively 3 online case report form for ANCA-associated vasculitis. And the patient has to fulfill the following criteria. The patient has to be initiated an induction remission treatment either for a new or relapsing disease between 2013 and 2016. And then they did start him on maintenance therapy. And the data were collected at induction, then at 6 months, 12 months, 18 and 36 months. And as you can see here, they did include around 1,500 patients, half of them with MPA and half of them with GPA, with the mean age was around 54. And most of them, they were male, and 44% had severe progressive disease, 56% moderate systemic disease, and almost half of them were incident, and the other half at the time of the relapse. And 30% from these patients, they were induced with rituximab and 70% with cyclophosphamide. The first beautiful finding from this study that these, physicians, they didn't define, the maintenance phase. Most of them, they said that there is no specific criteria for the maintenance phase. So it was like variable definition, but typically it starts around, as you can see from this diagram, between 5 to 6 months after starting remission induction therapy. And unfortunately, the other thing that I would like to highlight from this study is still the major and minor relapses remain a problem in the maintenance phase, unfortunately. And some patients died and some patients got infection, and mainly they got upper or lower respiratory tract infection followed by UTI. So still we are not doing great in maintenance phase. So they did conclude from this study that we are really in need for new therapeutic approaches to improve the clinical outcome in ANCA-associated vasculitis. Now I will move to the second study, which is, to me, it sounds to be a beautiful study, and I learned a lot from this study. Actually, this is the second randomized control trial comparing rituximab with AZA as a maintenance therapy in relapsing ANCA-associated vasculitis. We know that rituximab is an effective remission induction agent in ANCA-associated vasculitis, and it has been shown from different studies superiority to cyclophosphamide, especially in relapsing disease. But it has been clear that maintenance strategy is required, for which now lots of study now they are studying role of too many medication and maintenance phase. So the objective for this study to know what is the best maintenance strategy in ANCA-associated vasculitis, especially in relapsing population following rituximab induction especially, and what is the appropriate dose. And I will show you in the study design what is the dose they did use, and I will compare it with the previous study. The primary endpoint in this study was time to disease relapse reported at 24 months. So this is the study design for this study. So as you can see from this diagram, we have induction phase, remission maintenance phase, and follow-up. And they did follow this patient until 48 weeks, which is longer than the previous study, which is Menretsen trial. If you did remember, this trial was published in New England Journal of Medicine in 2014. In this study, they did induce this patient with high-dose glucocorticoid. Then they did titrate the steroid until week 20. While in Menretsen trial, okay, they did titrate the dose until month 18. So the induction phase, they did use in this trial rituximab at a dose of 375 milligram per meter square, 4 doses, 1 week apart, followed by 1 gram every 4 months until 20 months. While in Menretsen trial, they did induce these patients with cyclophosphamide, followed by rituximab, that's 100 milligram duration was longer, and they did compare rituximab to as study was 2 milligram per kg per day, and its fixed dose throughout the maintenance phase. However, in Menretsen trial, the dose was 2 milligram per kg per day and to be titrated every 6 months by half milligram. So this study, it's longer, and the dose of rituximab is higher and over shorter period of time, every 4 months. And the result was really beautiful. Again, the rituximab, as you can see, showed the superiority over azathioprine with a hazard ratio of 0.3, which is really beautiful. And the major relapses and minor relapses is lower in rituximab group. So they did conclude from this study that rituximab was superior to AZA for preventing disease relapse in patients with relapsing ANCA-associated vasculitis following reinduction of remission with rituximab. So we induce with rituximab and we follow these patients with rituximab. I think this is really interesting study. Now I will move to the last study in my presentation, which is, I think, sounds really beautiful to me. An increase in serum calprotectin level in ANCA-associated vasculitis patient during maintenance therapy is associated with more relapse and accelerated renal function decline. As we know, calprotectin is a protein produced from macrophages and neutrophil. And we know in patients with ANCA-associated vasculitis, the tissue infiltrates with lots of neutrophil and macrophage. And we know from the previous study, the level of calprotectin at the induction period is high. But the thing that we don't know, what is the place of this biomarker during maintenance therapy? So the objective for this study is to evaluate if serum calprotectin level variation at 6 months compared to inclusion, which is the M0, was associated with increased risk of relapse within 18 months of follow-up in ANCA-associated vasculitis. And the second outcome from this study to determine if calprotectin variation, I'm telling variation because it's not single reading, they compare from the induction to maintenance, what is the difference? If there is significant difference, it means this is really positive. And also to assess if calprotectin correlated with inflammatory parameters like CASR, CRB, and we know that we cannot rely on ESR and CRB in our patients because they are non-specific, and even ANCA level titer is non-specific, and it can be coming with relapse in some patient and in other patient not. So it doesn't follow the relapse in every single patient. So we need really a good biomarker to follow up our patient. So actually, they did include the patient from Menretsin trial, and they did take the patient with complete remission. As you can see, the score is 0. And after cyclophosphamide, they induced this patient with cyclophosphamide and the maintenance with rituximab or AZA. And the relapse, they define it if the BFS score more than 0. And they define the renal function decline from NICE 2015 guideline definition. I will take you now through the results. The first thing that you have to keep in your mind, that single calprotectin assay didn't identify patients with relapse. However, the calprotectin change, can predict for us a relapse, especially in patients with PR3 ANCA-associated vasculitis with significant, p-value 0.49, as we compare it with a whole study group. Another beautiful finding that calprotectin change predict as well a renal function decline in both group, whole study group and in PR3 ANCA-associated vasculitis with significant p-value in both group. So I can conclude from this study, what they said, that calprotectin reflect the subclinical inflammation occurring during remission leading to the relapse. And calprotectin can be an interesting biomarker to predict severe outcome as relapse or significant renal function decline during the remission maintenance treatment of ANCA-associated vasculitis. And these results must be, I think, confirmed like what they suggest in a future prospective study. So now moving to the take-home messages. Just concentrate with me. I think, after all these studies that I mentioned, I hope I didn't give you a headache. I think EULAR recommendation in 2020, it should be revisited again. And what I think, after all this study from 2016 until 2020, I think like what they mentioned in Bixivas trial, the role of plasma exchange doesn't improve outcome in ANCA-associated vasculitis. And if we can use now more rapid taper regimen for glucocorticoid to reduce the risk of infection, I think this is really beautiful finding. And we can, I think, try, for like complement 5 antagonist, instead of a steroid. I think really this is a beautiful finding to replace the glucocorticoid, especially in induction, and even we can use it in maintenance therapy to reduce the risk of infection. As we know, the risk of infection is very high in this entity of patient. Another, I think, message that I would like to deliver, if you have a patient with MPO ANCA-associated vasculitis, you can use Silsipt as induction therapy based on my study, which was published last year, 2019. Last message that I would like to deliver, that you can maintain your patient in rituximab, like rituximab trial, 1 gram every 4 months, but from Menretsin 3 trial, which was, as you remember, they did extend this maintenance therapy, and they did give patient rituximab until 36 months, and the result was beautiful. I think we can borrow as well this finding. The more you keep your patient in maintenance, the less relapse you will get, because we know the risk of relapse is really high, and we are really in need for more effective and safer treatment to treat ANCA-associated vasculitis. And thank you very much.